So today we're going to go through the airway assessment and patient positioning skill. So to start with, we'll just go quickly through the indications. So you've got preparation for intubation, other airway management, difficult ventilations, can't intubate situations, potential for airway deterioration in patients. Got identify and prepare a difficult airway, improve ventilation and potential improvement of shortness of breath symptoms, and safe facilitation of procedural management. So we'll start with the procedure. You want to make sure we've got our full 360-degree access around our patient. Everyone knows what's going on and everyone's on board, particularly if you're going to put in an SGA or an ETT tube or any advanced airway for that matter. Having the team on board is crucial. You want to go through your basics first, your primary, secondary surveys as quick as you can, dependent on the patient. So if we initially start with the airway assessment, if we have a brief chat about it, any airway emergency, you should be noting any partial obstructions through to stridors, hypersalivations, secretions, any snores, any obvious trauma to the face. And then you've got complete obstructions which will pick up pretty quick, so your silent chests, no rise and falls, obvious cyanosis of the patient. So if we use Bill here just as a quick example, we're just inspecting and noting the patient here. So we're just having a quick look if Bill's got any beard, apart from his ugly mode. We've got looking at mandibular protrusion, so any overbite and underbite. We'll go through this again in a moment. And the ability for the patient to speak clearly. You don't want to hear him talk, but he speaks fine. So we've got previous facial surgery. A good one is major dental complications, any dentures, false teeth, anything like that. So we'll go through the conscious patient and then the unconscious patient. So what we want to do is have a quick look, like I said, beards, facial obstructions, any abnormal trauma, deformities of their face, anything you're completely worried about, get someone involved early if there is. So we'll initially go through the Mal-and-Patty score. So we're going to get Bill to open his mouth and poke his tongue out as long as he can. So we'd probably give Bill maybe a class 2. He's got a good view of the tongue, back of the throat, and a soft palate up the top there. So you want to get your patient to open their mouth as wide as possible. In doing so, next thing we want Bill to flex and extend his cervical spine, left, right, up, down, sideways. So we've noticed we've got good extension, good flexion and good rotation, both 45 degrees. So we're assuming no difficulty through there. We want Bill to take a nice inhalation through his nose and mouth. Beautiful. So he's got clear nasal passages, no deviated septums, anything like that. So if we use the quick lemon assessment as we go through, we're evaluating, so we're looking at that mandibular protrusion. So if Bill can fit his own 3 fingers in his mouth through a good opening of the oral cavity, that's also good. We've got through here, we've got a nice mandibular protrusion of 3 of my own fingers as well as Bill's, and we've also got 2 fingers down through the cricoid down here. So we'd assume Bill has a relatively easy intubation or airway management and planning. And we've already established neck mobility, not obese, any risk factors there. Other things you want to be important of, just using your monitors and equipment to evaluate SpO2. We want to keep oxygen on this patient, high flow oxygen prior to any intervention that we go through with. Alright, so if we move down to the unconscious patient down here, we're going to be doing the same thing. It might be a bit difficult to put 3 fingers in their mouth initially, but a good way to do this is open through a jaw thrust, have a look at gauge what their Mal-and-Patty score might be. We want to do, provided there's no C-spine complications of trauma, any compromise, any blunt trauma, MVA, anything like that. We want to have a bit of a manipulation of their neck, see if they've got good movement upwards and downwards. We want to get this patient in the appropriate position. In doing so, we can use things like blankets or our kits in just a small sort of ramping just underneath the back shoulders. In doing so, what we're trying to do here is get the 3-axis alignment theory with their mouth, oropharynx and larynx, I believe it is. Have a quick look at that, yep. All in line, so we've got a good view through direct laryngoscopy, or if you can use a video laryngoscope, even better, just to mitigate the issues during intubation. Again, you want to pre-plan any complications of trauma. You want to get your secondary plan up, make sure you have lots of 360 access. You're going to think about front of neck access, airways, intubations and things like that. If we go down a little bit further on our skill sheet there, we'll have a quick look through considerations again. So most of the time patients will see this in pre-RSI. Also, you're looking at unconscious patients in arrests, and I think that probably about covers it. Surgical airways, yep. So front of neck access surgical airways, you just want to plan through that as well. Make sure you've got adequate positioning. You're marking your landmarks, talking with all clinicians on scene. Obviously a very difficult procedure, making sure everyone's on board. And I think that's about covers it for skills management and patient positioning.